Check, check. All right, everybody. Thank you very much for coming out. My name is Patrick Hayden. I'm the recent past president of the Wellesley Rotary Club, and we've been sponsoring speaker series here at the library for the last few years. And thank you, everybody, for coming tonight. We're very happy to have Julia Ragland here tonight speaking with us, and we're also going to have Cynthia Westerman, who's going to be making some comments. Before we kick it off, though, I just want to welcome everybody, and I want to say thank you for coming, and I want to bring everyone's attention to the fact that Taste of Wellesley is coming up, right, Vin? It's going to be good this year, right? It's going to be so Wednesday, May 21st. We did this last year. We've been doing it for a few years. We're going to have 350 people at the Wellesley Country Club. We have 15 different restaurants that will be presenting their best dishes. We're going to have a live band with live music. The weather is going to be 75 degrees and perfectly sunny, just like last year. It's going to be amazing. Tickets are $125. They're available over here. They're also available online. We use the proceeds from this to help relieve food insecurity in our town and in the region. And we also support a number of other initiatives here within the town, including scholarships for young students at Mass Bay Community College and sometimes at Wellesley High School, and some other things that we do related to parades and the things that go on around town activities. So, I'm being told I need to speak up. Sorry, Tori. Anyway, so with that, I will go ahead and turn it over to Cynthia Westerman, who will introduce our guest. And again, thank you everybody for coming.
Thank you very much, Patrick, and thank you very much to Wellesley Rotary Club. We are delighted to be able to be here tonight. Oh, thank you. Oh, I found actually, is that better?
What that is better.
Yeah, okay.
There you go.
Thank you. Might work for you too. So thank you again to Wellesley Club of Rotary for hosting us tonight, and also to the Wellesley Free Library for allowing us to use this space. So I am Cynthia Westerman. My role here right now is as the volunteer chairperson of the Palliative Care Council at Newton-Wellesley Hospital. And we're going to show you a couple of slides about what that is before I introduce Dr. Ragland. And while we're getting going, we've had some technical challenges that we're working through. So what is the Palliative Care Council? What is the Community Collaborative? There are 8 different councils that make up the Community Collaborative at Newton-Wellesley Hospital. And while Newton-Wellesley is part of the larger Mass General Brigham operation, what the Community Collaborative councils do is work in specific areas that are a little bit more intimate, sometimes we call, but also sometimes and frequently are also underfunded. So we work on advocacy, we work on community education, we help get people to the care that they need, but most of all, we also help educate people about how they can be healthier. And the councils actually cover a full spectrum of life and everything in between, because we have one called the Maternity Council, and then we go on to there's Heart, Health, and Wellness, and there's also a Substance Use Council. So we really affect all the communities that we serve. So if we will, on our flyer, there's actually a QR code. So if you're interested, if you'd like to get involved, if you'd like to join any one of the councils or donate to them, we encourage you to do so. With that, I would like very much to introduce our speaker tonight, Dr. Julia Ragland. She has been an amazing resource in our communities and also at Newton-Wellesley Hospital. She joined the hospital in 2002. Excuse me, thank you. This is part of the spectrum of life too. She earned her medical degree from New York University School of Medicine, and she completed her residency in internal medicine at Beth Israel Deaconess Medical Center. She's an associate clinical professor at Tufts right now, and she's board certified in both internal medicine and hospice and palliative medicine. After starting her career in primary care, she transitioned to hospital medicine. And when she joined Newton-Wellesley in 2002, first as the chief of the hospitalist service, she then also transitioned into becoming the founding director of the Newton-Wellesley Hospital Palliative Care Service, which since Julia's founding has also become a division at Newton-Wellesley Hospital with at least 12 in the clinical division, 12 to 16, I believe, right? Um, she is no longer the champion of the palliative care division. There's another wonderful doctor serving as that, but Julia is very active still in the palliative care division and particularly in education, which is why she is our selected speaker this evening. So, with that, we will see if I think this. I'm sorry. Oh, I see. Sorry, I didn't even think of that. All right.
I don't know if you wanted to add anything else.
No, I think we are so eager to
We're
hear from
ready.
you. Absolutely.
Okay.
Thank
All
you,
right.
Dr. Radcliffe.
Excellent. I'm up. How is the volume? My voice is, I should speak louder? Okay. Wow. No one ever says that to me. My husband's here and he can attest to that as well. Anyway, so I'm delighted to be here to talk to you about what you can all do to ensure that the healthcare you receive aligns with your values and priorities in the face of serious illness. As a physician who's worked in the hospital setting for over the past 25 years, I see firsthand how effective and ineffective communication greatly impact the patient and family experience. We have started a campaign in our palliative care council called Your Voice, Your Choice, which is also the title of our talk today. And the sort of sub part of our campaign title is Empowering Our Community Through Advanced Care Planning. And a key message is really that you all can have a say in your care and that the choices that you face along the way, and this will impact your life and well-being in different ways. We encourage you to speak to those who matter in your life, as well as to your clinicians when you're facing serious illness. And the more you speak up, the better your care can be. So I'm going to tell you now about a patient I cared for. Her name was Teresa. And this is an example, I think, of where good communication was very helpful. So she was an 80-year-old woman who was married with 3 kids. She enjoyed travel and tennis, but unfortunately developed dementia. She was living in an assisted living facility near her family and was doing okay, but then developed a mild case of COVID and subsequently started to decline cognitively and functionally. She was having some falls, she was losing some weight, and then she was admitted to the hospital with pneumonia and dehydration. She started to improve with antibiotics and fluids. Her labs looked better, but it was noted that she wasn't eating very well or drinking very well. And the team was concerned about the overall direction of where things were going for Teresa. So they set up a family meeting. And Teresa, because she had dementia, was unable to make her own healthcare decisions for herself. So this fell to her family, a family member was her healthcare agent. And what we learned in the family meeting was that Teresa was fiercely independent. She liked having control. She was that type of person. The family understood that dementia is progressive and ultimately a terminal illness, and that the team was sharing, together with our help, we were sharing what we anticipated for Teresa was that while she might recover from this pneumonia, that she's likely to face continued decline and be at risk for repeated hospitalizations, which is very common in the later stages of dementia. So we asked, what would Teresa say is most important if she could be here and know what the situation was? And what they said was they had had previous discussions with her. She had known people who had advanced dementia, and she said she couldn't be that person. She thought that that would be an unacceptable quality of life for her if she was fully dependent on others for her care. The family did not think that she would want to continue cycling in and out of the hospital, that she wouldn't want to be a burden, and that she'd even said things like she wouldn't want feeding tubes or being hooked up to mechanical ventilation to prolong her life. It was her wish to die in her sleep with dignity. So, given Teresa's overall condition and what her values and goals were as articulated by her family, we recommended that we shift the focus of care to comfort. She was able to go back to her assisted living with hospice care in place. As you can imagine, this is a very emotional situation for the family. No one ever finds it easy to make these kinds of decisions for their loved one. But this family had some degree of peace because they felt confident that they knew what Teresa would want because they had had conversations before. It's also notable that there was no conflict in the family. And often, what we see when there are not conversations in advance is if there are multiple family members, there are going to be multiple different opinions about what mom or dad would want. And so, this, I think, was an outcome that went well because of the preparation that was invested. So these are my objectives today and what I hope to make the case for all of you to do. The first is, if you haven't already done this, to complete a healthcare proxy. The second is to speak with your loved ones about what is most important to you in your life and in your healthcare. Speak with your clinicians about what matters most to you in the face of serious illness. And get expert help in the form of palliative care consultation if help is needed while dealing with a serious illness. So, as we look at sort of the course of life from young adulthood until we get older and develop a serious illness, regardless of what age you develop that serious illness, there are 3 steps that I think can help you and loved ones prepare for managing serious illness as health crises develop and prepare for the end of life that we all inevitably will face. The first is to choose a healthcare agent. And this is something that all healthy people, all adults should do. The second is to speak to our loved ones over the course of our adulthood about what matters most to us as we think about our health, what matters most to in our life, and we're thinking about future distant care. You're not facing an imminent decision at that point. And then the last, as you're facing a serious illness, is having conversations with clinicians about what your values and goals are and your thoughts are about healthcare. And the focus then is really on the near term, right? What are decisions you may be needing to face soon or actually in the moment care? I want to emphasize that this is not a one and done. We don't just have one conversation with our loved ones and think, okay, I've taken care of that, because our values and goals change over the course of our life. All right. So just to tell you a bit more to define advanced care planning, this is a process that supports adults at any age or stage in health in understanding and sharing their personal values, life goals, and preferences regarding future medical care. And as I mentioned, the first key step to doing this is to choose a decision maker, a surrogate decision maker. That is the person who you would trust most to make healthcare decisions on your behalf if you became unable to do so. Other names for that is healthcare agent or durable power of attorney for healthcare. To the healthcare proxy is the actual form that you complete that names who that person and or alternate person would be. And we recommend that all adults 18 and older complete a healthcare proxy. The sad fact is, a certain degree of young people will have sudden calamitous things happen to them, and they need a healthcare proxy, someone who can make decisions. If we don't have a healthcare proxy and we're an adult, decisions, how do we deal with that? Family will be called to make decisions. If family is all in consensus and there's no legal next of kin in Massachusetts, so it's whoever the closest relatives are. If the family is not in agreement, if mother and father or brother and sister and mother and father are not in agreement, there's conflict, and the patient can't make decisions, we have to go to a court to get a legal guardian. This is a disaster, and this is a preventable disaster if we all had a proxy in place. In addition, a couple of things that you should know is that you do not need an attorney. I think this comes up a lot in estate planning to do healthcare proxies, but you do not need an attorney. This can be done in any setting. You just need 2 adult witnesses who can attest to your sound mind. And those witnesses cannot be the people you are naming as your proxy, your healthcare agent or alternate agent. So I mentioned, why do we need a proxy? I mentioned one reason is we can have difficulties with decision making. It turns out that a significant number of people nearing the end of their life need decisions made by their decision maker. One study looking at over 3,700 people who were facing end of life and were unable to make their own decisions. 30%, I'm sorry, people who died over the age of 60, 30% needed a decision maker. So this is not a rare event. And I can say in the hospital, very, very common for people with serious illness to get confused in the setting of their illness. Many factors, medications can do it, and just being seriously ill. One other fact that I think many people don't realize is if you don't have a healthcare proxy and you are no longer able to make decisions for yourself, you cannot be moved into a skilled nursing facility. You cannot be enrolled in hospice. And these are situations where you need a guardian who can make medical decisions on your behalf. So it's a simple thing to complete, and I hope you all will do it if you haven't done it already. And if you have adult children or adult grandchildren, it's never too early for them as long as they're 18. The second step, we're going to go in much more depth, but is having those conversations with your decision maker so they know how to make decisions on your behalf. So, what are the objectives of advanced care planning? Well, it's really to prepare you and your loved ones for making decisions with clinicians that are the best possible in the moment decisions. In other words, we can't just pick and choose procedures and things and say, I want that or I don't want that, because you can't possibly know what the clinical scenario is going to be, what the pros and cons of each individual procedure is going to be. And it really is more about focusing on a desired or feared outcomes. What would make life unacceptable? What is acceptable? Do you know from other experiences with family members, certain situations where you're like, I just can't imagine living like that, Those are the kinds of things that can make a difference. And I'll give you some pointers on how to elicit that information or give that information to loved ones. Many people ask about living wills, and it can be helpful to document some of your thoughts about the kind of care you would want or not want, or what life would be acceptable or not acceptable. But there are many limitations to these. We often can't find those forms when we're needing them in a crisis. Sometimes they have very boilerplate, generic language that maybe lawyers had drawn up that don't really apply to the nuanced situations that we're facing. If the healthcare agent didn't participate in the creation of that living will, they may not know how to interpret it. So while they can help, they have limitations. And I think the other thing is that people's attitudes may change. They may fill out a living will, but then they never look at it again. And now 10, 20, 30 years have gone by and circumstances change. So while I don't say don't do it, because they can give us some general guidance, I think seeing a form that indicates that a patient accepts that dying is a part of life, and that when it's been determined that they are dying or on the road to dying, that they would want comfort focused care, that can be very helpful. It doesn't tell us about every decision in every moment, but just knowing that can be helpful. So there are many helpful tools out there as you want to embark on conversations with your loved ones. Some that come to mind is something called the 5 wishes. There's honoring choices, something called prepare for your care. But during my talk, I'm going to focus on one called the Conversation Project. I like the Conversation Project because I'm really trying to emphasize how important it is to talk to people. And they have free guides online for various steps of the process. They have conversation starters, how to choose a healthcare agent, how to be a healthcare agent, how to talk with a healthcare team, working through how to talk to your clinicians when you're faced with serious illness. Guides for caregivers of people with dementia. So incredibly helpful. This was created, it's a public health initiative, a public engagement initiative through the Institute for Healthcare Improvement. And Ellen Goodman, who was one of the co-founders of this project, She was motivated to start this because her mother had dementia. She had never had conversations with her mother about the kinds of things she would want or not want as she was nearing the end of life. And Ms. Goodman was faced with many decisions and struggled with them. And she basically said, quote, "The place to start this is at the kitchen table and not in the ICU. And it's with people who matter most before it's too late." And I think this brings up a phrase that we use a lot in palliative care, that it's too early until it's too late. And people avoid having conversations and they miss opportunities to make a real difference in the experience that people have in their final days, weeks, or months of their life. And I think what Ms. Goodman also emphasizes, which I think is so important, is that when somebody is very ill and they're getting closer to the end of their life, the whole process is intensely personal. And the events and how this all plays out sticks with their loved ones and the people who are left behind forever. So if we do it well, it makes a big difference. And if we don't do it well, it can have lasting, harm to those people that they care about. All right. So how do we do this? How do we get a conversation started? Well, one thing is you can approach someone and say, I want to talk about my priorities, for my health. If I'm speaking, my healthcare proxy is in the audience here, and I can say, Bill, I'd like to talk with you about what's important to me in terms of my life, but also in terms of my healthcare. Or I could say, Bill, I think I'm your healthcare agent. I would really like to hear from you. What are your priorities and thoughts about future healthcare? And so there, you can approach it from either angle. Starting it can be hard though. A lot of people are really nervous and afraid to do that. And so, of course, the conversation projects have some prompts here. Will you help me think about my future? I was thinking about what happened to Aunt Anne, and it made me realize that there are certain things I would want or other things that I wouldn't want. Even though I'm okay right now, I've learned that a lot of people end up in crisis and are unprepared. It's so important for me to be prepared. Can we talk some about things that matter to me? So these are all ways to open up the conversation. Sometimes you may encounter somebody who's resistant. And if that happens, that can be normal. And I think you can just validate and say, I know this can be really hard to think about or talk about, but you can say how it will help you personally. And what I know from experience too is that many people worry about having these kinds of conversations, but in the end, they're relieved when they're done and they feel glad. And it gives them greater connection with the person that they're having the conversations with. So here are some ideas of questions that you can talk about when you're having these conversations. I mean, what is the content? And I think that these are some beautiful questions to ask. What makes life worth living for you? What would make it not worth living for you? What are your hopes and fears about the future as your health declines? Are there specific religious or cultural factors that might impact your healthcare decisions? How have the healthcare experience of others impacted your thoughts about the kind of care you would want or you would not want? And, I think it's so critical to know that the answers to these questions are very personal. They differ from person to person, and the only way we can know them is to ask and to open that conversation. And then, as I mentioned before, doing this over time because people's opinions change and thoughts on this differ. And, sometimes people say, well, what do you mean? Like, what makes life worth living? I mean, for some people, it's being physically active, it's being able to be with their family and friends. They might, in their culture, believe that every breath is sacred. For people, say, well, what would make life not worth living? I can't eat ice cream. I can't recognize my family. I can't communicate with my loved ones. Those are the kinds of things. I can't watch the Patriots. I mean, it ranges, right? So you can get sort of creative, but it's really knowing those things. And I think that I think I finished there. Oh, I know. I was going to say opinions do change. I want to emphasize this. Young people, it turns out, they often think if something terrible happens, they suddenly became paralyzed and they're like, I would never want to live like that. But it turns out that studies have shown that people can adapt to many situations they never thought would be acceptable. But on the flip side, as we are aging and getting older, often when we're early in a serious illness, we want very aggressive medical care. We want to do everything we can to live longer and to pursue a cure. But as we age, as the illness takes hold on us, as the burdens of the illness and the treatments that we're going through, then other goals become important, non-medical goals. And unless we talk about those and know about those, we don't end up addressing them. So it all sounds good, but how do we know? What are the benefits of advanced care planning? So uh, I think, people avoid having these conversations. They think they're going to harm somebody. They're going to create anxiety or distress. But in fact, you may be making it harder on your loved ones by avoiding those conversations. So studies have shown that a third of people who are the surrogate decision maker who have to make those end of life and difficult decisions for someone suffer negative emotional consequences, including guilt, complicated grief and bereavement, and PTSD. And those studies also show that if people are prepared, they are much less likely to suffer those consequences. So you may be helping to prevent emotional distress for your family, just like the case of Teresa that I just mentioned. The other thing is that conversations about things that we can't control can actually give us a sense of control. It's trying to just make it a little bit more manageable. And we have to acknowledge, while we may not be able to predict every choice that we'll have to make, we can give our loved ones some guiding principles that will help them confidently make decisions for us. And that is our hope. So I'm going to transition now to serious illness. And I first want to just define, what do I even mean by serious illness? This is a sort of fancier decision, a health condition that carries a high risk of mortality and either negatively impacts a person's daily function or quality of life, or excessively strains their caregivers. I think shorter version, I would say that most of these, and these are the more common ones, are not curable. They tend to progress over time. There's a risk of sudden deterioration or death, and there's a high burden on caregivers and patients. And so the common ones that we see, most common, are advanced cancer, advanced liver disease such as cirrhosis, dementia, or other progressive neurologic disorders like Parkinson's, ALS, congestive heart failure, kidney failure, COPD. We have lots of patients who have multiple of those all at the same time. And then there are others as well. And people certainly can have sudden life-threatening illness. They can have sudden infection with overwhelming sepsis. They can have a catastrophic injury. But these are the things, when I think of seriously ill patients, this gives you an idea of what we are seeing. So I'm going to tell you about a seriously ill patient that I cared for a number of years ago. And this is a case, a different kind of case. This is a case of missed opportunities. Mr. A was a 75-year-old who had congestive heart failure, COPD, sort of emphysema, and some chronic kidney disease. He was a veteran. He had had 5 hospitalizations in the year prior. He was living alone, and his family lived out of state. Each hospitalization got more difficult. He had increasing symptoms of shortness of breath. He was needing home oxygen, taking many medications. The hospitalization where I met him, he was admitted to the ICU setting with shortness of breath and found to be in congestive heart failure, but also developed acute renal failure. And he was faced with a sudden decision of facing end of life or going on dialysis. Unfortunately, the patient and family were not really prepared for this. And it felt very urgent and rushed and in a crisis. And he chose to start dialysis, which I think just about anyone would in the crisis, if the choice is die or start dialysis, without any thought, being able to really process that. So unfortunately, he had not had any prior conversations about prognosis. And prognosis means not just time, but what is life going to look like? What is life likely to look like in the future when you have heart failure, chronic kidney disease, and emphysema? What's important in his life? What's he willing to go through in order to gain more time? What's acceptable versus unacceptable quality of life? What gives his life meaning? So there had been no exploration of any of that. I met him after he was stabilized and he transitioned to the medical floor. So he was getting dialysis. And I asked him, what is the hospital experience like? Common question that I ask in my field in palliative care. What is the hospital experience like for you? And he said, terrifying. And I said, well, what's bothering you most? And he described many physical symptoms, including pain from a urinary catheter, pain from repeated blood draws every day, IVs, cardiac monitoring. None of these are all treatments that we're giving and monitoring. They weren't even from his disease, but he also was short of breath, fatigued, didn't have energy to do what he wanted to do. His appetite was poor. He had nausea. Um, I was called on to the case because he was questioning whether he had made the right decision, whether he should have started dialysis or not. And so we had a patient and family meeting and learned that, talking to him, I said, well, how have things been? What have you been able to enjoy recently? Nothing. Well, I learned that he said the past entire year he's had a terrible quality of life. And we asked what was most important to him, and his main priority was to spend time with his family. I have to mention that his daughter was actually a physician. So I mean, this happens to us too, like we think, we know it all, but our brains go in a different zone, when we're talking about our own family. But the family lived out of state, and that was his priority. So ultimately, we stabilized him. We made arrangements for him to move into a skilled nursing facility to be near his daughter and to continue hemodialysis. It turns out a few weeks later, he decided, with support, to stop the hemodialysis and went on hospice care and died within a couple of weeks with his family there. And I heard back from his daughter. We had made a good connection, and she was very grateful for the care that her father had received at Newton-Wellesley, and he'd been at Newton-Wellesley many times. But she thought, as did I, that we could do better. There were many missed opportunities to prepare him and his family over the multiple hospitalizations. And how about during the time in between those hospitalizations, when he was seeing his other doctors or the other healthcare providers in his care? Many of the decisions could have been anticipated. The transitions felt very abrupt from life prolonging and potentially curative care to end of life care. And they felt that care was fragmented and there was no one really seeing the big picture over that last year of his life. And I think this is an example of it's too early until it's too late. I mean, there had to be people that could see where this was going, but everyone probably thought it's too early or they had other reasons why they didn't bring this up. Um, Sadly, this case is not atypical. Um, and what I said is they're unaware that the prognosis was poor. These are specific quotes from the daughter, and they wish they had gotten information sooner. They felt unprepared for the decisions they needed, and they regretted that there was not more time for closure. And as I mentioned, this is not atypical. It turns out that studies show that conversations between patients and their clinicians about their prognosis and goals are infrequent, with less than a third of people in some studies with end-stage diagnoses having that kind of conversation with their clinicians. And when they do occur, they happen very late. One study looking at patients with advanced cancer found that on average, the first conversation occurred 33 days before the patient died. And 55% of those conversations happen in a hospital with a doctor they never knew before. So our hope is that we can collectively, everyone in healthcare fields, certainly in my field, and in the community, I think collectively that we can do better. That pressure from patients and families and clinicians to change the system that currently prioritizes technology and volume of services as well as throughput over time spent on these meaningful and valuable conversations. So this is a wonderful quote that I like to use by Dr. Atul Gawande, who wrote a book that I highly recommend if you've not read it or heard of it, called Being Mortal, Medicine and What Matters in the End. People turn out to have priorities in their life besides just living longer. We need to ask people what their priorities are, especially when they have a serious illness or frailty. If we don't ask, our care and what we do to people isn't aligned with what matters most to them, and then you get suffering. And I can honestly say, as physician and working in a hospital setting, we worry, the nurses worry, physicians worry, the social workers, the case managers, but particularly the ones delivering the hands-on care. We worry at times, are we causing more harm than good with some of the things that we're doing to people? And sometimes that light bulb goes off, and that's when people think to engage in conversations about where things are going. So this is a cartoon I pretty much committed to including in every talk I ever give in palliative care. I'm right there in the room and no one ever acknowledges me. And it's a personal favorite because I can apply it in many things that I talk about. But I think the elephant is really that possibility that serious illness is progressing and that end of life may be nearing. It's rarely brought up by patients and families or by physicians. And this results, as we just heard, in missed opportunities for patients and families to address both non-medical goals, to address their non-medical goals. Some ideas of what that means: non-medical goals, avoiding suffering, maximizing time at home, mending relationships. And I'm going to have a bit more on that in a second. So unfortunately, as you can tell from what I've said, serious illness care is often provided in suboptimal conditions. Studies have consistently shown that patients and families, when they're dealing with serious illness, have very limited understanding about their illness and what to expect in the future. Also, studies consistently show that clinicians have limited understanding about what their patients value most and what their goals are. And teams of healthcare professionals have limited time for coordinated conversations. So what we end up with often is the blind leading the blind. We quickly move in a hospital setting to, we're going to do this test, this procedure, and we just don't stop and take stock of what does this all mean? Where is this going? What are we hoping to accomplish? In an ideal setting, a patient and family would know what their life is likely to look like, what is medically possible. The physicians will understand what each patient values and what they hope to accomplish. And the physician and advanced practice providers will help guide the patients and families by making recommendations that align what is medically possible with what matters most to that patient. I've mentioned several times this concept of goals of care. And that I view as their medical goals. A framework in my mind are we fighting for cure? Are we fighting to prolong life? Are we fighting to maximize function? Are we fighting to maximize comfort? Now, most patients have a foot in more than one camp at a time, but it's sort of a spectrum and a way for us to think about with our patients, like where are we at? But there's also non-medical goals. Are there things like attending a life event? Many people, it's important. I want to fight to live until I make it to my daughter's wedding. I want to make it to my granddaughter's graduation. I want to make sure that I've dealt with my financial matters. I've prepared my funeral. I've mended my relationship with God. So each person has different non-medical goals. So, a serious illness conversation program was born out of the recognition that we do not have enough of these shared conversations between people with serious illness and their clinicians. And the mission of the program is to improve the lives of all people living with serious illness by increasing meaningful conversations about personal values and goals with their clinicians. And Dr. Atul Gawande and his group, the Ariadne group, started this. They created a guide. I don't know if anyone has read his book, Checklist Manifesto, but he's a checklist guy. So this started first as it was going to be a serious illness conversation checklist. And then I think they decided that seemed a little cold for something that is so kind of emotional. So it became a guide, which you can see in the middle here. And the guide is a template to help teach us and guide us in having these complex conversations. It turns out that physicians, certainly in my generation, were not trained at all in how to have these conversations with patients, nor nurses or advanced practice nurses or anyone. So we have a lot of catching up to do. And this program, a key piece of it is that this guide is something that is scalable, teachable, and that is what we've been doing. So the guiding principles of the program are that serious illness conversations help people focus on how they want to live in the face of their illness. Patients want the truth about what to expect. It'll vary from person to person. There are a small few that want zero information, but most people want some information. As I just said, people have goals beyond living longer, and it empowers us as clinicians to know something about them. And then we also train clinicians that giving patients an opportunity to express their fears and worries is therapeutic in and of itself. Even if we can't fix someone, we can help them by just talking about it. So the guide, there are key steps for the clinicians on the guide. They're basically assessing a patient's illness understanding. We give steps and language to providing prognostic information. There are questions here to help explore what is important to the patient. We then summarize what we've learned and make recommendations based on that. And then when we train our providers, we train them to respond to emotion, because there's no way to talk about serious illness and the future without having emotion. And I've just lost my train for a second here. 1 second. We've been training people on doing this the Serious Illness Conversation Program has been implemented in many health systems, including Mass General Brigham. We've been training our providers at Newton-Wellesley for over 10 years now. We've trained over 700 people. We have benefited from generous philanthropic support, which helps fund this. We have actors come in who play seriously ill patients, which makes it very real and a little bit tense, but is an amazing half-day learning experience. So we're trying to get the word out. So we talk about, we know from studies that there are benefits of early values and goals conversations with clinicians. And I gave you 2 examples. I work in a hospital, so I'm often having late goals of care conversations, people in crisis, we could be at the end of life conversations. But the goal of the Serious Illness Conversation Program is to have that guide and to train people who are on the front line in the community, the primary care doctors, the specialists who take care of people with serious illness, whether that's neurologists, cardiologists, nephrologists, oncologists. And we want to encourage the people who have a longitudinal relationship with patients and families to have these conversations. It's certainly more comfortable. It's much easier to have a conversation when you're not in a crisis, when there's not an immediate decision that needs to be made. And so we also know from studies that having conversations earlier before crisis provides more time to make informed decisions, reduces the burden of decision making for families. It improves patient and family coping. One study looking at the serious illness conversation, when a physician has had that with their cancer patient at the Dana-Farber, they measured anxiety and depression, and the patient's anxiety and depression went down 1 week after the conversation and was better for 6 months following that conversation compared to the people who did not have that serious illness conversation. This is mind-blowing. Doctors avoid having these conversations because they're worried they're going to make their patients anxious and depressed. And in fact, having a conversation makes them less so. People with serious illness are already anxious and depressed. They're just worrying alone, and we help bring that out. So the next is that we know from studies it increases opportunity to fulfill personal goals. Another study from the Farber found that 2/3 of patients who engaged in a serious illness conversation with their oncologist engage in positive behavioral change. They planned their funeral, they did their will, they arranged something special with their family, built legacy. So there definitely are positive benefits, and we think the earlier the conversations happen with clinicians, the better. It also, this is something we really emphasize to the clinicians who are anxious and worried to have these conversations, is it really deepens the patient-clinician relationship. A lot of us went into healthcare because we wanted to help people and have these meaningful connections with people. And when you're caring for people where you're running out of medical options to fix them or save their lives, there are still really important and meaningful things we can do to help them all the way until the end. So here are some tips for speaking with clinicians. I think one is you can ask for a dedicated visit to discuss the future with your illness and what matters to you. Or you can just let your doctor know in my next visit, when you're following up about your medications or your blood pressure or whatever, that's something that you'd like to talk to them about. Medicare created a billing code for providers in 2016 to encourage us as providers to actually have conversations about advanced care planning. And that can be a separate visit or it can be embedded in a routine follow-up visit. I encourage you to prepare for the visit, write down your questions, ask for the information that you need, ask for clarification when you need it. It can be incredibly helpful for people who have a serious or complicated health situation to bring a buddy because that person can help take notes, help you process what was said. If any emotional content is being discussed in the meeting, it can be hard to process information. And if you have a proxy form or living will, you should bring that. So how to prepare for conversations with your clinicians. I think I wanted to just let you know that if you or a loved one has a serious illness, the Conversation Project has a workbook called What Matters to Me, a workbook for people with serious illness. They literally took the questions from that serious illness guide that clinicians are being taught on and put it in a format so that the patient can answer the questions for themselves or think about them before they're going to go meet with their doctor. What is your understanding of your health? What information would you like? What's most important for you to have a good day? What are your most important goals if your health situation worsens? There also is a guide for potential questions for your healthcare team. I'm not going to go through all of these except to say, I really just want to encourage you all to take some control over communication. I think some people are timid about what the questions they want to ask their doctor. Ask for information that you need. That information is power. You cannot make informed decisions unless you have all of the information about what's going on. And then also just feel empowered to share with your clinician what matters to you. I want to acknowledge, though, that physicians have their own anxieties. As I said, they worry that they are going to make you anxious or depressed. They also don't like to talk about sad things. They like to think about the best case scenario or hope for the best and the positive. And so I think it's I mentioned this before, but our system also doesn't support or encourage these conversations. The clinicians are under tremendous time pressures, financial pressures, and they're frankly not reimbursed as much for conversations. And these are the real challenges that we're up against. All right, so you have serious illness, and sometimes expert help is needed. And I would say expert help is needed when you're getting mixed messages from clinicians, the family's in conflict, and decisions need to be made. The medical recommendations seem to be at odds with your personal, religious, or cultural beliefs. The clinicians that you're interacting with aren't giving you the information you need or want. You're not getting enough emotional support, or you have poorly controlled symptoms. And this is when we would recommend requesting a referral for a palliative care consult. So palliative care, specialized medical care, this is a short definition, that treats the symptoms and stress of a serious illness. The goal is to improve the quality of life. So these are some different aspects to clarify further how it works. So we work as a team of doctors, nurses, advanced practice nurses, social workers, chaplains, sometimes others. We actually have a therapeutic musician on our team at Newton-Wellesley. We are specialty trained. There are fellowships, board certification now in hospice and palliative medicine. We work closely with the patient's other doctors and providers. They do not need to give up seeing their other doctors. We are involved based on the needs of the patient. They don't have to have a certain short time frame of prognosis. It just needs that they have serious illness and they have needs that are not being met by their regular providers, and may be provided together with curative treatment. Key aspects of palliative care. I mean, the first is symptom management. So we assess and manage physical symptoms, whether that's pain, nausea, constipation, shortness of breath, you name it. Emotional symptoms, very high burden of emotional symptoms in serious illness or spiritual distress. We focus on bidirectional communication, not surprisingly, what we've talked about illness understanding, medical decisions they have to face, learning what's most important to them to ensure that medical care is aligned with their goals. And then we help a lot with coordination of care. In particular, we help when doctors and other providers are not all seeming to be on the same page. So one of our things that we do is really bring everybody together to try to put together a cohesive consensus picture of what this patient is facing, what are their options, and what the future may look like. So why do we need palliative care? Well, there are many people living with serious illness and they are suffering. And the fact is, because of the wonders of medicine and how much we've done to prolong people's lives, to help them live longer with these illnesses, unfortunately, there are a lot of people out there, and there's going to be growing numbers as our population ages, who are also suffering while they're going for life-prolonging treatments, which most people want, by the way. Family and caregivers are overwhelmed. The caregiving burden is incredible as they're navigating this, complex and chaotic healthcare system. Poor communication is common, care is fragmented, and coordination is often lacking. Just to highlight a couple of more statistics, but study looking at people with serious illness, 62% have anxiety, they feel confused and helpless. So, more than half of the people, and I can say that with absolute certainty of the people I see in the hospital. But in terms of the fragmentation and chaos that people with serious illness face, the data from 2019 showed that the average Massachusetts Medicare patient in the last 6 months of their life, on average, they had over 26 physician visits. That's the average. Over 26 visits in the last 6 months with almost 14 different doctors. So it's no wonder it's confusing and chaotic. Now, I put here wanted to mention another book and an author. The Best Care Possible is by Ira Byock, who's a palliative care physician. And I love the way he described the best care possible and linked this to palliative care. As palliative care providers, we want to find out what the best possible care means for you in this particular situation as you and your family look ahead. And I think that really sums it up quite well, is what we're doing in palliative care. I think this also says how we really help bridge gaps and focus on living as well as possible in the face of serious illness. So some people want to understand, okay, well, how does it work? I mean, okay, you call you in, what does that mean if Dr. Ragland and her team is called in on a case? Well, first of all, anyone can ask for us. I speak mainly from the hospital experience because that's what I have the most experience with. We get anyone on the healthcare team, it could be the nurse, case manager, it could be a patient or family member, can ask for palliative care, but we do need to have the attending physician on board. They are the doctor in charge of that person's care, and it's rare that they wouldn't say yes. And the main reasons we get consulted are that the patient, family, and team feel that they need help clarifying what are we working towards? What's the big picture here and what are the overarching goals? Patient or family struggling with how aggressive to be. How much do they want in terms of life-sustaining treatments? Should they go for that, big surgery? Should they start hemodialysis? Those kinds of decisions. We see patients that have symptoms that the primary team just can't manage. We have a lot of cancer patients with very difficult pain management and other symptoms. So we're expert at managing those. If there's conflict, differing opinion among different physicians, or if there's conflict in a family, we will often be brought in to try to get everybody together. And then if there are complex cultural or spiritual issues that are affecting the healthcare decisions that are being made or moving a case forward, they will get us involved. So we first do an intense chart review. We do a deep dive in the medical issues that are at play. We look at the different specialist notes. We will speak to the different providers on the case. And that may be physicians, but it also could be the social worker. It could be the physical therapist or a speech therapist. And we try to come with some consensus about their health, what's possible, what decisions they're facing, and our key intervention. We don't do surgeries, we don't stick lines in people, we don't prescribe chemotherapy. Our key intervention is the patient and family meeting. And in that meeting, we have to build trust very quickly. So we spend time getting to know that person as a person, learning how their life is impacted by their health, what is it like to be in the hospital. What are their hopes and worries? What information do they have now about their health? What would they like to have? And then we have often multiple meetings, sometimes involving other providers and maybe a key specialist like an oncologist, or maybe sharing a meeting with an intensive care unit doctor. Often family is present, and we will talk it through to talk about what's possible and what is most important to that patient in that situation, and then make recommendations. And then we will share whatever decisions are made, try to be a bridge against all those providers so that we're all on the same page moving forward. The typical new consult takes us about 2 to 3 hours of time. We are fortunate that we have, in a typical day for me, as compared to my other physician colleagues, I will only see maybe 5 to 6 patients a day, and usually 1 to 2 new consults, and the rest would be follow-up visits. And the only reason that's possible is because the hospital supports our work, and we have a tremendous amount of philanthropic support, which has helped to support our service. So we devote a lot of time. We do multiple visits on a hospitalization, and we often see patients over multiple hospitalizations. A lot of our patients are still wanting to continue to come back to the hospital, and they will see a familiar team when they come back if needed. All right. So palliative care is also provided in other settings. So I've talked about the hospital. This is the field of palliative care developed in the mid to late 90s in the hospital setting to meet the need, I think, of crisis management, as I said, sort of short interventions and helping people when they're really suffering the most. But there really is a recognition that we need a big effort to support people earlier in their journey with serious illness, when they're at home and when they're where they want to be. And so palliative care is expanded both into the office setting, primarily in the cancer care setting, and also in home settings. So I'm first just going to mention office settings. So the office is different. We have providers on our team that are embedded in the Mass General Brigham Cancer Center at Newton-Wellesley. They work in conjunction with the cancer doctors. Patients are referred usually who have advanced cancer, maybe incurable, often with high symptom burdens. And our palliative care providers will follow them longitudinally, usually over months or years. And things unfold over a slower time course of getting to know them, of helping with coping, sharing of information, having those advanced care planning conversations, serious illness conversations, and all the time managing symptoms. And when these patients get sicker, if they end up in our hospital, our team will see them in the hospital. And that's very comforting to our patients to know that, they're following with a team that all works together and collaborates. One just quick case to mention, because I've told you really only about inpatient cases. This is a pretty amazing case that involved both our inpatient team and outpatient team. 45-year-old gentleman diagnosed with metastatic colon cancer, had at diagnosis had a major surgery, had a lot of complications, had intense amounts of pain, ended up in the hospital for 4 weeks, having difficulties with nutrition, having difficulties with pain. And so we were nausea, we were helping with symptom management. But this is also a young family. He's married, has young kids at home, coping with this horrible diagnosis, the anxiety you could imagine, the disruption to their lives. He stabilized, thankfully, and went home and has continued to follow with our palliative care colleagues in the cancer center. It's amazing. It's been over a year. He's been in the hospital only like once or twice briefly for pain flares or symptom management crises, but mostly has been followed with the expert help of my colleagues who are managing him with incredibly complex regimens outpatient. And so they are maximizing this family's time together at home with their kids and at the same time preparing for what everybody knows is coming, that eventually the cancer therapies are not going to work for him anymore. And so just wanted to give you an idea of how that works. Home-based palliative care is less well developed. We actually have two representatives back here from Good Shepherd Hospice and Community Care. I point that out because a lot of the home-based palliative care is provided by home care agencies, hospice organizations, or sometimes health systems. We have our own Mass General Brigham home-based palliative care program. I think this is an area that's well underdeveloped and is going to grow because, again, when people are sick, they want to be home. They don't want to be going to the doctor. They don't want to be going to the hospital all the time. But because funding being the way funding is, there are limited resources to support this at home. So I now consider referral for home-based palliative care in patients who either don't have cancer and are not going to be followed in the cancer center, but often it's in patients who I think are getting closer to the end of their life, but not yet ready for hospice, and also patients who are less able to get in and out to their own doctors and specialists. And so that way there's somebody, usually an advanced practice nurse who specializes in this, who can be checking in monthly and collaborating with the primary care to talk about how are things going, what's important now, are there ways we can improve their quality of life. So a final quote about palliative care, Diane Meyer, who's a leader in the field, palliative care is about living as well as you can for as long as you can and helping to lift the burden of living with an illness. And I also wanted to share this beautiful photo of a patient that I saw a couple years ago. Her family gave me permission to share this. Her name was Cookie. She was in the hospital with cardiac and pulmonary disease. She'd had a few hospitalizations. Her condition seemed somewhat tenuous, and we thought her prognosis was most likely measured in weeks to months. And we had a family meeting and talked to her about that and asked, what was most important to her. And she was very clear that she did not want to keep coming back and forth to the hospital. Her priority was to go to the Cape, to spend as much time as she could with her families, and to spend time outdoors seeing the sunsets on the Cape. And so we, given, the state of her health, her somewhat limited prognosis, and her goal to be comfortable and avoid repeat hospitalizations, we recommended hospice. And she left with hospice, and I heard back from her family. I literally am giving chills again. About 5 months later, she lived for 5 months, and they reported that she had many wonderful sunsets at the Cape and made many beautiful memories with her family. And I share this, I think, as an example of a positive outcome that can come in part because we had a frank discussion about what was really going on and clarify what was really most important to that patient and family and made recommendations that aligned those two. And it made that outcome possible. There's some luck there. She could have died suddenly any time. We didn't know that. But I think without those steps in place, they couldn't have had that positive outcome. So I'm happy to say I'm wrapping it up. Take-home messages for all of you is that completing a healthcare proxy ensures that someone you trust will be making healthcare decisions for you if you become unable to do so. You can speak up and have a say in your care, having conversations with those who matter most about what matters most to you, which we call advanced care planning, puts you in the driver's seat. Telling your doctors what matters most to you will help ensure that you get the care that's right for you. And palliative care provides an extra layer of support. You can have quality of life while getting treatment for a serious illness. And the last slide is what you can do now. So this is your homework assignment. You can complete a healthcare proxy form, and if you have already, you can do a little assessment if everyone in your adult in your life, if they've all done that as well. Regardless of their age, as long as they're 18 and older. Explore the tools at theconversationproject.org. Talk to your loved ones about what's most important in your life and your health care. When facing a serious illness, speak with your clinicians about what matters most to you. and ask for expert help in the form of palliative care when it is needed. Thank you so much, and I'm happy to take questions. Any questions? Comments? Yes.
I have to ask this question. The quality of life issue. I mean, when I look at quality of life where I am right now, I couldn't golf, I couldn't walk my dogs. I mean, that's a quality of life. But we seem like we're all in the slope of where that's going to go away from me, and then there's another. And I don't understand that yet. And the step beyond that, I don't understand that yet. So it would be helpful to. I'm having trouble in the framing square. It'd be helpful to know that as we reach those steps, that the people who are successful with the quality of life beyond those, that they are having quality of life that is acceptable.
Well, that's it. Okay. Yeah, I can. I think I can. I think the question is, it's difficult in your current state, like his quality of life is playing golf and, other active things. And it's hard to like project ahead of what would quality of life mean in the future, when I couldn't play golf or if I couldn't, did I get that right? So I think that's hard for a lot of people to think about. I think some people who have the biggest advantage when we're asking them questions are those that have already walked down this path with someone else in their life. They have seen a parent die or a grandparent die or, some experience already because it becomes a little more abstract. But I would say that even knowing those things. You can go a little deeper if you use some of the questions that I showed up there. What makes life meaningful for you? There are things I think that you would say that are very meaningful to you that go beyond golf that probably don't require you to physically even be able to get out of a bed, right? It's time with my loved ones. It might be prayer. It could be, listening to music. Everyone is different, but it's like stretching your mind to but I think even some of us who can't, I mean, I guess I can imagine more because I see it all the time. But, it's like for me, I say to my family, like if I'm not making my own decisions and I have advanced dementia, that's not how I want to live, like I don't want you to prolong things. So that's what I tell them. I mean, I could change my mind, but so it's, just trying to think outside the box, or if you know of people in certain situations.
Like something grow, striving for something.
Yeah.
So the future now is something maybe less than.
Yes.
It's nice to know what that goal is.
Mm-hmm.
So the goal is to read more. The goal is to,
yeah. So one of I mean, that's the other thing is you do see people, their goals shift, right? As they can't do these things that they love, they get to, and I think what I find is that the people who still are able to engage in things that are really meaningful to them, they're enjoying interactions with family and friends, they are not in pain all the time, they enjoy food still, they can read, and they're not suffering too much from physical symptoms. I mean, I think that's the other counterbalance is they may enjoy those things, but they are suffering so much from pain that it just makes it unbearable for them. So I think if they, as long as those people, even though their life might be very compromised, and the other main question I ask them too is, what is this like being in the hospital and going through all this? And if someone's like, this is fine, this is making me better. And so they're happy, they're good, they're content at this point in their life. And they're like, I'm willing to come back because it's still making me feel better and I'm enjoying playing bingo and whatever. But becoming very limited. Absolutely. Yes, that's right. I think just for everyone to hear that, he was just told that yes, there is life after golf. So it may be hard to imagine, but as we mentioned, I mean, younger. So maybe you're younger. You're like that younger person who thinks I could never live paralyzed, but then when they're paralyzed, they adapt to that situation. So that's why I think being fixed in our ways of thinking is not very productive. It does change, and it changes a lot, though. What I can tell you is when I start getting answers from patients, and this happens a lot, what do you enjoy now in your life? And when they say nothing, then I'm like, okay, now we may be causing more harm than good with all these things that we're doing. We need to really evaluate, what's happening here. And even in that circumstance, most people can hope for things. And you know what they start hoping for? That I die in my sleep, that I am out of pain, that I'm not a burden on my family. Like there are always things you can hope for, even as things, get very narrow. Any other questions?
Yes, Dr. Ragland, this has been so.
I don't know if we know if anyone on Zoom has any questions, or is there any way to know?
We're monitoring
okay.
it, yes. So informative and so helpful. And when you first started discussing about what are one's priorities, I thought, I don't know, I need some examples of priorities. And what really helped me was hearing about ice cream. I mean, it can be that small, right? Or you said enjoying food, but even if it's ice cream, that is something perhaps that one's loved ones or kids could halfway understand, right?
Yes.
And use when the time comes, because when the time is there, it can be pretty rough. I think about that as being the healthcare proxy for my own mother and no other, generally daughters who have done the same. And as you said, it's very impactful for the rest of their lives. But I have a question, and that is, in trying to start the conversation, you gave us so many good tips, but what about the loved one who is not really very connected to other people? And when you try warmly to bring it up, always says, yeah, I'll think about it. Yeah, yeah, later. I mean, and years can go by. Have you, certainly I would look forward to being able to share that with a particular loved person myself when we have the recording, which will be sent to everyone. Yeah. But have you any quick suggestions for that?
So I think one point that I had mentioned before too is framing it, if that person cares about you, how it will help you. And maybe they would be inclined to do something they would not want to do, but they would want to do it because it's going to help you feel more in control or better prepared, or you're worried that you're not going to honor their wishes, or that they aren't going to have someone honoring their wishes, or something like that. But the other thing too is, I think, to have some curiosity. I sense that you don't really want to do this or talk about this. I wonder if you could tell me why. And you might get an answer that could help, and open that dialogue up a little bit more. Because we in palliative care get people who don't want to answer our questions either. Or talk to us about some of the things we talk about. So those are some strategies. How can it help, either help that person? If you've probably tried that already, how can it help that person? How can it help you? Or just being curious and exploring, what are the things that you're worried about? What are what's blocking us from moving forward here? So.
Thank you. So helpful.
Any questions?
Yep. Okay.
Thank
you so much.
So much.
Yes. All right. Turn that off.
Wow. Thank you again, Dr. Ragland.
Is it being recorded? Yes, it was recorded. And
it will be available on the Wellesley Public Media website. Yeah, these get posted on the Wellesley Public Media website and on YouTube. Oh my God. Yes, you're going to be famous. So thank you very much.
Always a relief.
That was great.
Oh, it's yeah. A couple of hiccups, but
Yeah, he was ready to shut it down.
Huh?
He was ready to shut it down.
I know. Well, yeah, late for them. It's a lot. It is. I know. It is a lot. Yes. Yes. Yeah, are there normal speakers? How long do they talk?
Something over here for a second. Okay.
Yeah. I of course took longer than I practiced.